This is my work on PRP and tranexamic acid for pterygium surgery. Fibrin glue is a very popular product in pterygium surgery because of its high fibrinogen content. It provides strong adherence. The flip side is viral transmission risk and risk of prion diseases. Fibrin glue is allergenic and allergenic antigens are exposed to the patient. Long-term safety of fibrin glue is unknown. Prion transmission risk is difficult to diagnose and treat. The product is also not free of naked viruses. This paper highlights how tough it is to remove the viruses. The answer perhaps lies in this centrifuge where patient's blood is spinning to generate platelet-rich plasma. Autologous PRP can reduce transmission risk. PRP is obtained by following steps. Patient's whole blood is withdrawn by a 5 ml syringe attached to a 24 gauge needle. Minimum 2.5 to 3 ml blood is required. Avoid smaller syringes and needles. Change the needle on the syringe to avoid skin pathogen transmission. Transfer the blood to a sterile cuvette. 20 gauge needle is required for faster transfer. Cuvette is placed in a 4-well centrifuge opposing a balance and run at 4000 rpm for 3 to 4 minutes. In centrifuge, blood is slowly clotting by a slower intrinsic pathway. After pricking the skin, within 7 minutes we have to inject it under the graft. Under graft, PRP will clot instantly as the pathway is shifted to extrinsic pathway. Observe the interface between the RBC and platelet-rich plasma because the separation has to look complete. Handling should be gentle because we don't want the components to get mixed. A fresh 1 ml syringe is dipped in the PRP and avoid dipping it into the red part. Attach a 24 gauge cannula. A larger cannula is required because the PRP is viscous. Remove air and now PRP is ready. This slide shows the summary of all steps. Time is of importance, otherwise we get pink or clotted PRP. Before using any centrifuge, always check for balancing tube. So we begin the surgery as per standard methods. Subconjunctival and topical anesthesia is used. A surgeon need not modify his preferred methods for excising the pterygium, for measuring the graft, and for positioning the graft on the conjunctival defect. Once the bed of the graft is ready, it is washed with tranexamic acid and 0.5 cc of tranexamic acid is injected into the subconjunctival space. Injecting tranexamic acid before PRP allows the drug to bind with the tissues. Up till now, platelet-rich plasma is not prepared. Only after the graft is layered on the conjunctival defect, then the surgery is paused and the steps for PRP preparation is done. There would be a break of 5 minutes here for PRP preparation. To inject PRP, I hold one end of the graft and begin the injection from one end and proceed towards another end. The idea here is that the whole graft should float on the PRP. With 2 suture tires, the graft is ironed vertically first and then it is extended on the temporal side. Avoid excessive ironing, otherwise PRP gets squeezed out entirely. Using green filter provides good tissue definition. This is a very important step. A Q-tip is rotated in this manner to pick up the excess PRP. A suture tie is moved circumferentially like this to make sure that there is no connected fibrin on the conjunctiva. Excess PRP is connected to the undergraft fibrin and lid blinking can dislodge the graft if not removed. Speculum is removed, eyelids are cleaned thoroughly and the graft is checked. It should not get dislodged by lid blinking. The eye is patched for 24 hours or longer. Steroid, antibiotic and lubricating drops are given. This is the postoperative image in a different patient. Lid edema and watering is common postoperatively. This is a different patient. 6 months postoperative, different patient. Now why do we use tranexamic acid? When fibrin polymer is formed, our body destroys it by fibrinolysis. Aprotenin in fibrin glue prevents fibrinolysis. I chose tranexamic acid with PRP because of its lower risk profile. Aprotenin is bovine origin and tranexamic acid is a synthetic analog. The BART trial banned aproctentin use for quite some years, but later aproctentin was reinstated. This is a nice paper which lists all the studies which compare both the drugs. Safety profile of tranexamic acid is better than aproctentin. All cases of color blindness with tranexamic acid had received very high doses of tranexamic acid, and our conjunctival dosing is very less and it gets diluted by a blood volume before it reaches the retina. This slide shows how clinical dose of tranexamic acid was calculated. I have highlighted a solution C, which is an ideal dose, but I have moved to higher dosing because it is very safe. These are my post-operative outcomes for the procedure. For success in pterygium surgery, in zone 1 we want fibrosis of the subconjunctival space, and in zone 2 we do not want proliferation. PRP is rich in platelets and platelets is rich in alpha granules. All these factors would have a positive impact on the graft host adherence. From this paper, I prepared this table which summarizes all the functions of the alpha granules. Fibrin glue will have none of this. So we have to understand that in zone 1, the area under graft, there can be a positive impact of platelets and WBCs. In support of fibrin glue, if you look at this paper, it shows that level of fibrinogen and fibrin glue is very high compared to PRP. However, we also have to look at the quality of fibrin polymer, and this is a very nice paper which quantifies the type of fibrin polymer that is generated by different PRPs. The bottom right image shows that the fibrin polymer is thicker if it is studded with the blue leukocytes and the platelets, and the top left shows you that it is thinner if there are no cells. One added advantage of using PRP is that because we don't have two components, the patients do not require a peribulbar block. Postoperative bilateral graft, 6-month-old.